So welcome everybody. I want to personally welcome you to the MedRhythms Videocast series. This is episode 2, which is a monthly series where we're going to be talking to world experts in the field of neurology, research, rehabilitation, and music, discussing all things rehabilitation, music and neuroscience, digital therapeutics. Each month we'll feature a new expert who will provide valuable insight into these important topics. This show will be hosted by me, Brian Harris, the co-founder and CEO of MedRhythms, a digital therapeutics company focusing at the intersection of music, neuroscience, and technology to build interventions that transform lives around the world for those living with neurologic disease and injury. If you'd like to learn more about MedRhythms, please visit our website at www.medrhythms.com. I hope you'll find today's episode interesting, meaningful, and compelling, and I believe that you will. Today, I want to introduce our esteemed guest for this series, Dr. Michael Thaut. Dr. Michael Thaut is currently a professor of music at the University of Toronto with cross appointments in rehabilitation science and neuroscience. He holds appointments as a collaborative scientist at the Neuroimaging Division and as an affiliate scientist at the Li Ka-shing Knowledge Institute at St. Michael's Hospital in Toronto. He is director of the Music and Health Science Research Center and Music and Health Sciences graduate programs at the University of Toronto. His appointment is endowed by a Canada Research Chair Tier 1 award from the federal government of Canada. Dr. Thaut received his master's and Ph.D. in music from Michigan State University with a cognate minor in movement science. Dr. Thaut is an international leader in the basic and clinical neuroscience of music and has internationally recognized research in relation to the applications of auditory neuroscience, specifically for music and rhythm, to neurologic rehabilitation. He has over 200 scientific publications and is the co-editor of the Oxford Handbook of Music Psychology, the senior editor of the Oxford Handbook for Music and the Brain, and the Oxford Handbook for Neurologic Music Therapy. He is the president of the International Society for Clinical Neuromusicology and vice president of the International Society for Music and Medicine and an overseas fellow of the Royal Society of Medicine in the UK. He and his team developed the clinical system of neurologic music therapy, which is evidence-based, applied worldwide in neurorehabilitation, and endorsed by the World Federation of Neurorehabilitation. This includes the development of rhythmic auditory stimulation, which we will discuss today. Dr. Thaut is also the founder of the Academy of Neurologic Music Therapy, the organization which trains all clinicians in neurologic music therapy around the world and promotes best practices in the field. Welcome, Michael. It's an honor to have you with us today.
Thank you. Thank you, Brian. It's good to be here.
And for full disclosure, Michael is an advisor to MedRhythms, and I also sit on the advisory council for the Academy of Neurologic Music Therapy. So, Michael, just to get us started, we'd love it if you could tell us a little bit more about your focus of research, and also maybe give us a background on the Academy of Neurologic Music Therapy and its mission.
The Academy, I'm actually a co-founder, so I'm not the only founder. Was created in the early 2000s, basically to give the training, the neurologic music therapy training, a home that kind of can set the standards, and so a platform also for communication and advancement. So this whole thing came into being because we started doing a different kind of paradigm research in music in relationship to brain rehabilitation and therapy in general, away from the traditional social science-based model of traditional music therapy, which is sort of still in an adjunctive status, and we try to change those kind of underlying assumptions in terms of, is there something clinically relevant in how the brain perceives processes and produces music, clinical translations, in other words, out of music perception, music cognition, and music production. So we actually, the first thing we studied in terms of musical elements was rhythm, because I knew this from my own experience as a musician, that rhythm is a key element in learning how to play music and perform, but also in terms of how music is constructed. And so RES really is based on rhythm perception. Okay, how does the brain process rhythm perception? How can that clinically translate into changes in motor control? So that research actually was extremely successful. We started this in the early around 1991, 92. I was appointed at Colorado State University, and I had some funding. And so we could actually engage in that research by equipment to do this. And the effects were pretty dramatic. And then we went from there through the same paradigm of looking at music perception, production, cognition in other applications for motor control and motor rehabilitation, but also speech and language and for cognition. So that stuff was so well established in the community where I expected the most resistance, which was in the neuroscience and neurology community. By the late by 1999, 2000, the question that was posed to me and my team from neuroscientists and neurologists and other rehab professionals was not, is this valid? Does this really work? Because there were other studies that had sort of replicated our findings, and I think we did a good, thorough job to make sure that this research is well organized. The question was a completely different question. The question was, who can do it? And that kind of baffled me because I hadn't really thought about this. I thought this would sort of trickle down from a knowledge point into general music therapy, et cetera, et cetera. But it never did. And so we had to come up with a educational trajectory, which was really not something that I had ever really anticipated. But it was very clear if I show up at another World Congress of Neurology and tell them the new discoveries, the question would, that's great, but somebody needs to be able to do this. So the traditional music therapist doesn't do this stuff. That's what they told me. We have a music therapist, but they don't know how that works. They do different stuff. So the other rehab professions would understand the research mechanisms, but they don't know anything about music. So they're sitting right in the middle there between a couple of chairs or more. So this is why we decided to start organizing the academy, and also in order to create techniques in a more formalized way based on clusters of evidence. And so the academy is sort of the guardian of this system that has evolved with a lot of input from clinicians into a system of 20 standardized techniques that are really well known. RES was the first one we created, and RES is now in medical standards already accepted in the US and in Canada. So that's a little bit about NMT, and the academy has, I think, 4,000 active members. The total training is more like we probably trained 5,000, 6,000. There's a faculty that travels around. Right now we're traveling in Zoom land and not in airplanes, not much anymore, but that will probably come back. And 6, 7, 8 international training institutes per year. And so this is a big movement of knowledge that's medically also established at this point in time. My research right now is more mechanism oriented. We're not doing any RES clinical trials with GATE. We may do this again at some point in time. We have done clinical trials here. We just completed a big stroke study for upper extremity with TIMP. This is a NMT technique mapping functional movements onto music instruments. So that came, we just were ready to send out one paper next week, and we have another paper in the works, more a kinematic paper and on that, and that actually was a part of the dissertation. So in terms of RES research, we're looking especially with Parkinson's right now, mechanism issues. We do neurotransmitter imaging. So how does the addition of rhythm as a movement cue, how does that change the biochemical basis in the brain in relationship to dopamine and basal ganglia function. That's a big project. We published one paper out of that, and we're stepping forward to the next levels. And we published a fMRI study looking at inter and intra-brain network connectivity with the influence of music. We can't have people walk in scanners, so we have to kind of simulate that with hand movement. And we also did the recording intracellular stuff, in terms of basal ganglia neurons, how they fire in response to rhythmic auditory stimuli, cueing. Once again, we have to have arm movement because we have a research center here that does DBS implant surgeries. It's a two-step process the way they do it here. So after the electrode is implanted, they actually leave the wire connections outside exposed for 3 or 4 days. And so we can actually clip on and do intercellular EEG research and look how the neuronal output changes with the effect of rhythmic stimulation. So it's all very interesting.
Excellent.
And confirms in many ways that this is not just a behavioral effect, but it is RAS and other techniques in NMT operating on the remediation impairment level, brain plasticity level.
Absolutely. Well, thank you for that background, Michael, and for setting the stage there. And, I think today, as you mentioned, some of this new research that you're doing specifically to RAS, and I'd like to dive into that a little bit. But I think to get started, obviously, rhythmic auditory stimulation is important to MedRhythms. It's sort of what we're building with our digital therapeutics to really figure out how do we bring this incredible research and this incredible intervention more to the people that need it. And now that we have this really sort of mechanistic understanding and sort of that this is more than behavior change, right? That this is something much deeper than that and sort of how this works. But if we, dive into rhythmic auditory stimulation, just for our viewers here that may not be aware, could you just define the intervention and then give us a high-level explanation of how rhythmic auditory stimulation works neurologically or why it works?
Rhythmic auditory stimulation came out of the idea that auditory rhythm can change, can influence and modify and shape movement. And so there is a natural tendency between the auditory and the motor system to entrain. In other words, the motor response locks into the auditory rhythmic response. The whole business of dance is built on that. And we have the same basic intuitive reaction to rhythmic beats. And so we were thinking that if this helps the high-end performance, can that also be a turnaround in terms of rhythmic stimuli helping to modify and reshape movement that's been dysfunctional. And so we looked at stroke first because we wanted to have a very clear, consistent anti-rhythm in movement. And so to test if this RAS stimulus, the sensory stimulus RAS really works. So we picked probably the hardest arrhythmic nut to crack, which is the paretic walk in stroke patients. So you have this consistent anti-rhythm, so to speak, short, long. And then we looked at rhythmic stimuli, just isochronous, regular, steady beats, rhythmic stimuli embedded into music, or just sometimes pragmatically it can also be delivered by metronome. And we wanted to see if this entrainment effect that I experience as a musician or a dancer or as an athlete who uses auditory stimuli, if that is powerful enough to actually change the motor control output in a stroke patient who has a damaged motor control system. And so that actually happened. And that was well established now in stroke and Parkinson. These two populations are probably the best. There's some studies, a little bit of study in traumatic brain injury in some other areas. So rhythm perception is very powerful in terms of projecting into other brain areas that are responsible for motor control. And the basic effect, you can imagine that sort of as a lock-in effect or entrainment effect, where the auditory neurons fire, obviously in a steady frequency, and they're synapse to motor neurons, and the motor neurons begin also this fire in the same frequencies, steady frequencies, and that then changes the planning of the brain in terms of movement and in terms of anticipating moving the paretic leg earlier to get it off the ground quicker so that it becomes more symmetric and more stable. So that's a sort of bottom up and probably also top down effect in the brain, where the auditory system sort of locks motor regions into that kind of frequency harness. And we have looked at this from an fMRI level. We are looking at dopamine right now, but we've done a lot of kinematic analyses. We have done EEG research where you can actually capture the temporal aspect nicely. Mm-hmm. And so the physiology of this has been now also documented in the beginning. We just saw that and measured that clinically, and we measured it kinematically, but we didn't know exactly what was going on in the brain. Now we have a very good idea what's going on in the brain, and we can actually lay out the mechanisms, how the auditory system interacts with other parts of the brain in terms of driving the motor system into this different kind of planning scheme. Is stuff pretty well documented now.
Excellent. And you talked about those early studies in stroke and PD. You know, was there a moment in that in those early studies where you sort of knew that this was going to work, or that you knew that you were onto something?
When I saw the first patient walk, I knew it. Mm. It was so dramatic that I actually showed this to one of the development officers, our very first study we did at the university, and she sent this to Good Morning America. And lo and behold, a group from Good Morning America showed up in 1993 or 1994 and did a feature on that. So that the effect is so clear that it doesn't take a whole lot of big data management to figure this out. It took ways to figure out how the underlying physiology works, but the neural mechanisms, but that it works clinically, you can see and you can test that with very good clinical assessments, kinematic assessments, and that was immediately clear.
And what, you know, as you think about, you talk about the kinematics and we think about biomechanics and the improvements that are possible with rhythmic auditory stimulation, what are those sort of clinical improvements that you've seen in research, and what are the populations? You've mentioned so far Parkinson's disease, stroke. What other populations would we expect to be able to see some of these clinical outcomes, and what are those clinical outcomes?
The clinical outcomes are a little more specific to the types of populations we work with. So there's definitely a stroke. All the basic gait parameters improve and become entrained. So stride length, step frequency, which is are the drivers of speed of walking, velocity. A big issue is symmetry, stability. So all these basic gait parameters, which are essential for functional movement, improve. In Parkinson, symmetry is not that big of an issue in Parkinson, but bradykinesia, slowness of speed, shuffling, gait patterns, unsafe gait patterns, so where the ankle drive doesn't work properly, so they land on the wrong part of the foot, freezing. So all these things change with this auditory input. The mechanisms are probably universal because stroke and Parkinson have very different neuropathologies. So what works in stroke normally wouldn't work in Parkinson, but in RAS, it works in both. And so the principles of motor control in terms of the anticipatory, predictable, regular time input into the brain should work across a lot of populations. So we don't have to have for every single type of movement dysfunction a major RCT. So it would be nice to see more in terms of traumatic brain injury because there are also some cognitive issues involved. We see on a completely different level some motor control improvements in autism, which there's not a movement disorder, but it's a more connectivity dysfunction in the brains of those kids. So the principle of RAS should basically go into orthopedics, spinal cord injury. They're sort of stable, universal principles of creating predictable, regular auditory temporal input, which harnesses all the other parts of motor control. Actually, it also works and is actually used quite a bit. Not RAS necessarily, but the same idea underlying RAS in sports.
Well, it's interesting. Let's dive a bit in more into the science a bit. I know you've been doing some recent research, some that's been published, and I think some that hasn't been published yet, looking at dopamine, specifically in the ventral striatum, across, I think, perhaps aging and Parkinson's disease. What have you found there, and why is it compelling?
We have the dopamine study is a three-step study. Where we looked at, since this is so new, no one has ever looked at this, we needed to go into healthy populations first. So we did the young healthy, and we published that in Frontiers in Neuroscience. We got interrupted with the healthy elderly. We have 3 more to go, then we have that sample completed. So we're very, very close. And then after that, we have now major funding through a huge endowment that we have received. We have the money, we have the funding to go into the actual Parkinson population now. The interesting thing is what we found with the young, that there was actually, when the movement was cued and entrained to musical rhythm, there was actually a reduction in dopamine output or uptake. So in other words, instead of increasing dopamine release, the music seemed to reduce the reliance on the dopaminergic system. And actually in the healthy young group, we actually saw an increase in dopamine when they did the self-paced movement for a long period of time. So this could be an interesting hypothesis that we didn't expect, that since the dopaminergic system in Parkinson's is kind of compromised, heavily compromised, a substitute input that reduces the reliance on the basal ganglia and dopamine system there may actually be very helpful, because it reduces reliance on a system that's deficient. Okay.
Yeah, it's very interesting. Do you have a time? You're in the midst of that PD study now, right?
Yeah, because we were obviously interrupted for at least 6 months, not being able to do imaging.
Right. I mean, I think the other very compelling thing here in some of your more recent research, even specifically as it relates to PD, is the sort of correlations to falls, right? So we know that gait biomechanics, gait speed are largely correlated with somebody's fall risk and their falls. And we know that specifically in Parkinson's disease, that people fall often. I mean that's really applicable across sort of the aging population as well. In MS, there's 50 to 70% of people who have MS fall within a 6-month period because of their gait deficits. And we've sort of, I think for a long time with the transitive property said, well, if you can improve walking, then you can likely improve somebody's or reduce somebody's fall risk. You actually showed that in Parkinson's disease in one of your recent studies. Can you talk about that?
Yeah, we published that 2 years ago in Neuropsychology. That was a long-term study, 24 weeks. So 8 weeks, the control group and the experimental group, both the RES group, both trained with RES daily for 8 weeks. And then the control group was stopped training. So it's a classic sort of medication trial, withdrawal trial, and then they're trained again. The RS group continued to train for 24 weeks. So, and then we measured a whole bunch of a large repertoire of kinematic measures in terms of velocity, stride length, cadence, balance, dorsiflexion of the ankle we were very interested in. And we saw a significant reduction of falls in the RS group and the control group during the first 8 weeks.
Mm.
During the withdrawal phase, actually the fall index increased again in the control group when they stopped training. And then when they started training up, they started catching up, not to the full level of the continuous RES group, but they got better again. So that was a very positive finding because there is no real understanding why people fall, and there's also not a real good understanding of what can we do to prevent falling. So the best predictor for somebody falling is a previous fall, which is obviously not a very satisfactory condition.
Right.
So we were excited about that finding, and we looked at ankle because the correlation, the strongest kinematic correlation with the falling reduction was in the dorsiflexion of the ankle. So the dorsiflexion is the flexion of the ankle, which is in 2 moments critical. When you take off your foot in a swing phase, you have to dorsiflex, otherwise you drag your toe and you fall. And then before landing, you have to flex again so that you land safely on the strongest part of your foot for weight acceptance. So walking without RES, the ankle drive was very flat. Okay, so we looked at angular acceleration profiles that was kind of very flat, so very unsafe walking. So it didn't really do this cyclical movement there during the swing phase. And as soon as we added the metronome, in this case, I think we just used the metronome for that kind of aspect of the study. We could see that the time information embedded in rhythm sort of became a continuous time reference in terms of, oh, okay, now I have to flex my ankle. I have that much time before I land because the next beat, I know when the next beat comes, but I need to land. So the ankle drive became sort of regulated by the additional augmented time information. So that's probably one of the mechanisms why we saw this significant reduction in falls.
Yeah, it's an important outcome. I mean, falls are important metric to the healthcare system. They're very costly. I mean, they're important to people's lives, to their independence, but these are the things that I think move the needle for the field as well, for getting the healthcare system to understand the importance of these types of intervention. And as you mentioned, there's really nothing out there, or there's not many things out there to say that we can actually have an impact on falls. So I find this to be very exciting research.
Yeah, I think what RES addresses is timing, the timing system in the brain. And I think most interventions don't have a structured time input. A typical physiotherapy doesn't really works with timing. They don't have timing stimuli. They have good stimuli for positioning of movement, spatial orientation, those kind of things. What music adds and what rhythm adds is what we know as musicians. It structures timing in the brain. And the timing system in the brain is probably the system that sort of controls the rest in motor control. And I mean, the change in position mathematically, the first derivative is velocity. The second mathematical derivative is acceleration. So if you so it works down, it worked itself down in terms of motor control it scales itself down through the whole timing system.
Mhm.
And this is where I think RAS is unique,
Right.
because it provides a timing information and a timing plan and harness
Right.
that we as typical healthy people don't need for most movements, but the injured brain needs that harness to be provided from the outside. Healthy people, super healthy people, need it again if they become high performance athletes, because their movements are so fast that the brain internally cannot control that anymore. And they actually use a lot of gymnasts, a lot of rowers, and a lot of athletes actually work with auditory rhythmic stimuli.
Very interesting, and interesting to think about it being used purposefully in that way, Michael, in terms of whether it's athletics here, and also thinking about the difference between this and, as you know, doing the research, that this is much different than somebody just listening to a playlist in the background and walking with music on, or even training with music on, that there's really a purposeful element here.
Yeah, it has to be purposeful. Or you can actually do some damage if you don't do it purposeful, because then, sometimes in the Parkinson, we actually have to slow down the patient because the step rate is too fast. That the steps get shorter and shorter and too fast. So if they listen to an exciting piece of music and somebody says, yeah, RAS, I heard about RAS. I mean, you just should walk following that band, that how they play, that nice rock and roll kind of thing, or whatever, or punk, whatever. That could actually have disastrous consequences.
Right.
Or if you make a stroke patient at a early phase, give him a step frequency that is too fast, that could have catastrophic tendencies. Right. Because the link between the auditory system and the motor system is not a sort of spurious link. It's actually a very strong physiological link. Mm-hmm. So it has to be done. It has to be done with therapeutic knowledge.
Absolutely. Well, yeah, thank you for that perspective. And we actually have one question here that I'm from the audience here, Michael, that I'm going to ask you. This is from Dr. Randy Blackschaffer, who is the medical director of the stroke unit at Spaulding Rehabilitation Hospital in Boston. And she says, can you say if it's only rhythm that has an effect, or does pitch and harmony make a difference in terms of an effect on gait?
Gait is probably rhythm, because that's an internal rhythmicity that we enhance with this external rhythmic input. Now, there are other techniques in NMT that actually use more of a complete musical architecture. For instance, pattern sensory enhancement, Ph.D, is essentially, in simple terms, moving to music outside of gait. So full body coordination, getting up, standing, sit, stand, whatever, rotation, turn, coordinating your arms, etc., etc. So that's where what we call sonification becomes important, in terms of you can communicate not just speed of movement, but also strength of movement, spatial direction of movement with pitch, timbre, harmony, etc., etc. So this is where, outside of gait, in other types of movement rehab, that complete sonification picture paradigm becomes important. And then, of course, one of my favorite techniques really is TIMP, because this is essentially clinical translations of music production. Mm-hmm. Have usually percussion or keyboard instruments, and we can map functional movements onto those instruments. And so they practice their flexion extension exercises, shoulder flexion extension, trunk rotation, whatever, mapped on musical instruments. And then you have also the three-dimensional package you have. There's, first of all, the motor arousal due to sound. You have the rhythmicity built in, because you need to have, even in TIMP, you need to have rhythmic cues. And then you have the knowledge of results when you, at the end point of your movement, you get augmented auditory feedback that you actually got there in the right time, in the right place. And so RES for gait, that is really, you can enhance with good harmonic and melodic structure, of course, if you embed the rhythmic stimulus into music, then everything that enhances the sense of rhythm, and that could be also for harmonies or pitch, that's good. But it doesn't give you more than an augmented time information. Whereas in Ph.D. and TIM, the whole sound architecture of music, actually in 3 dimensions or 4 dimensions or whatever, is actually can be very, very important.
Excellent. Thank you for that context there, Michael. And we're coming up on the end of our time here. So I have one final question for you as we think about rhythmic auditory stimulation. Sure. What does the future of RAS research look like? You know, from your perspective, what are the next questions that need to be answered as it relates to this intervention?
Well, I think we want to research, we want to solidify some of our mechanism research. I think we want to maybe research actually how RES can interface with some cognitive interventions, because we're looking at some data here that we collected where actually cognitive function in TBI at an early stage of recovery can actually predict how they do 12 months later in walking. So some interface there would be interesting to look. I mean, obviously one should look in larger studies at traumatic brain injury, at MS, at orthopedics. Those populations should be studied. One important issue is, and I think that touches in your particular interest, is we need to also look into technology, effects of technology in terms of intelligent devices that give the patient more autonomy and independence to intensify their independent training. And we need to look at how can that be delivered. And we probably made more, in the last point, we probably made more progress in the last 6 to 8 months than we ever thought we would, because we were forced to get everything online. Right. So that's a important point, but you also need to have an intelligent device that you can actually then deliver online.
Right. One, as you mentioned, that can be therapeutic in its approach and not random. You know, there needs to be a clinical and therapeutic intuitiveness or smartness about the product.
Yeah, absolutely.
Well, thank you, Michael, so much for your time today. It's been an honor to talk to you, as it always is when we have our conversations. And I want to thank you for the work that you've done for the field, and you know, for rhythmic auditory stimulation, and the impact that you've had on the lives, and allows us to do the work that we do. So appreciate you being here today.
Yeah, one last moment, one last comment. I don't know if the audience knows that RES is actually in the official stroke guidelines in the VA system and in the Department of Defense in the US, and since 2019. And about the same time, it was also adopted through the Heart and Stroke Foundation, which sort of sets the critical healthcare guidelines in Canada for stroke. So RES is really at this point in time, in official medical stroke care guidelines.
And really demonstrating the foundation of evidence that really supports the work, and one step closer to being standard of care for everybody. And now it's just figuring out how do we deliver it to everybody. So thank you again, Michael, and thank you all for being here. Thank you for watching. Also, keep an eye out for our next episode, which is going to be in January, where we will be announcing the guest for that episode very soon. As a reminder, if you'd like to watch this episode again, or you want to learn more about MedRhythms, we are actually recording this, and we'll have this live on our social media, as well as on our website at www.medrhythms.com. If you want to learn more about the Neurologic Music Therapy Academy, please visit their website as well, which is www.nmtacademy.co. So thank you very much. Michael, we'll talk again soon, and thank you for being here.
Thanks. Take care.